Good morning, everyone. Thanks, everyone, for your patience. It's very apt this morning because we're going to be talking about technology, and we just had to deal with some technological challenges to get things all set. Very excited to introduce this morning's Pediatric Grand Rounds given by Dr. Albert Tu. I'll begin with a land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia. We honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nation, Inuit, and Métis peoples and their variable past, present, and future contributions to this land. So today's presenter is Dr. Albert Tu, who is a pediatric neurosurgeon here at CHEO. He trained at University of British Columbia, and there is where he initially developed his interest in spasticity, complex spinal cord malformations, and brain and spinal tumors. He then completed a fellowship in the Children's Hospital of Los Angeles in California, where he gained further experience in the management of spinal dysraphism, epilepsy, and endoscopic approaches to the brain. He then started as a staff neurosurgeon at Children's Hospital of Minnesota, and then came back to Canada and joined us here at CHEO and University of Ottawa a few years ago. Albert is currently the team captain of the Mind Matters team at the CHEO Research Institute, and has worked closely with members of that team to adapt technology, including AI, to help kids with cerebral palsy and other movement disorders move better, and you're going to hear more about that today. The title of his talk, Adapting AI for Use in Motion Analysis for Patients with CP. Albert.
Good morning, everyone. Thank you so much for that kind introduction, Jason, and I'm so sorry I'm late. I grew up in a generation of computers, but I still can't figure them out, and I apologize in advance, which is ironic because I'm doing AI talk today. Spacebar.
All right, we're gonna do. Okay, nope.
Thank you. Again, I'm supposed to be an AI person, but this clearly has defeated me. So there's a couple disclosures. Some of the technology and some of the research that I'll be sharing today is foundational to a startup that myself and some of my collaborators have started called Movalytics. And we will be talking about some of the process and steps to get to that point as time. And if you have questions, I'm happy to talk about that technology as well in more detail, or the process going through company starting, because it's a pain cave, and I'm happy to share my experience. All the work that you'll see shared today was supported by internal and external research grant funding. We'll talk about what I think AI is, how we define it, very superficially. I'm not a computer scientist, and if there are any in the room, I apologize in advance. But we'll also talk about why we use motion analysis in kids with CP, as well as understanding some of the steps it takes to go from taking a question, a clinical question, and trying to adapt to technology to answer that question. Patient of mine, 8-year-old male, known diagnosis of CP, history of prematurity, classic, stay in the ICU, living at the home, a little bit of community therapy, but they're in a resource-limited environment, and they're referred for the question of further management. I don't know if you guys can see this. You can appreciate that he's got an abnormal gait. He needs some gait assists. There's something wrong with his ambulation. Pretty classic for cerebral palsy. For those of you who aren't familiar with this, just to make sure we're on the same page, cerebral palsy is the most common neurodevelopmental disorder. Affects about 1 to 2 for every 500 live births, and what that translates to is within Canada alone, we've got 85,000 patients more who have a diagnosis of CP, and by 2030, we're looking at 2,200 patients, 2,200 new diagnoses every year. The predominant feature in cerebral palsy is a movement disorder, and classically we always talk about it in the context of tone, spasticity, dystonia, spasticity being like a velocity-dependent change in your movement, dystonia being like a passive, not requiring that sort of movement to induce that abnormality. But these kids also have other issues with their strength, their coordination, and there's a very high incidence of cognitive impairment in patients with cerebral palsy as well, reaching maybe anywhere from 30 to 75%. We usually quote about 50%. And what this translates to is that even if you're trying to fix one problem, you got to consider all these other aspects of their deficits when thinking about some sort of management paradigm. Physical therapy is the cornerstone to looking after these kids. Can't say enough about it. Anything we do, physical therapy is like first line. But there's also pharmacologic management. There's systemic therapy, there's focal therapies, there's tons of surgeries we can do. I know I'm just listing a few here as examples, but there are many, many, many different orthopedic surgeries that can and are being done for these kids. And there's a few neurosurgical ones as well. Some of them are very effective in some patients, some of them are less effective. And we pick and choose which therapies we think are best for the patient. But, we look after a lot of these kids. I look after a lot of these kids. Many of my peers and colleagues in this room look after a lot of these kids. And we all have different opinions about what to do. And it's because there's so many different phenotypes for the same diagnoses. And even within the same phenotype, there's multiple treatment paradigms possible. So kind of a diagnostic as well as a management dilemma. Like, what do we do? How do we pick and choose the most appropriate therapies? These are 3 different patients with cerebral palsy. And you can appreciate that all of them have very, very different ambulatory changes, very, very different movement type disorders, movement patterns, and all of whom are going to get very, very different treatment approaches. It might not be a one-stop shop. This might be patients who get multiple different types of treatments. So one of the tools that we have at our disposal is something called gait analysis. Everyone in the room is kind of familiar with this technology. And by the way, this is a stream of consciousness kind of talk. So if you have questions, comments, interactions, please, I encourage it. But in gait analysis, maybe people have heard about this, maybe not. You see it in the movie industry all the time, sports, gaming. 3D gait analysis is a proprietary technology that's marketed by many different companies. There's like different brands you can buy. One of the most common ones is Vicon, but there's other ones as well. They're all kind of the same in principle. You get body markers placed on you, kind of like those big balls you see in like mocap type applications. You get a bunch of cameras, usually in 12 to 16 in clinical applications. They're fixed around in a big room. And they're basically acquiring visual data all the time to abstract some sort of kinematic information. Some gait labs also have force plates. Some of them actually put EMG on patients as well as you're going through the motions to try to get a sense of what muscles are firing and what's not. And what you're really trying to do is abstract kinematic information, both direct and indirect, to try to put together some sort of plan or map in place about what the movement abnormality actually is, trying to quantify this deficit. What's the problem? As you can probably imagine, a setup like that is expensive. It's hard to build. You need a big space. It's a fixed mount. It's expensive to maintain. Technology itself, you need technologists to put it together, to look after it. And it's a subspecialty training to interpret. Like, you're basically a PhD, a postdoc in biomechanics, kinesiology, to actually interpret the data you're getting back. So there's not many places that actually have this technology. This map, where the gold stars are, I think you guys hopefully can see that, shows the locations where we have clinically available gait labs in Canada. Ottawa's not one of them, but a lot of Canada has none of them. And if you look across North America, there's I think it's 280 some odd certified pediatric hospitals. Something like 18 have a gait lab available for clinical use. So not very many at all. So the question that I came upon when I came here to Ottawa was, how do we improve accessibility to this technology? And in discussion with one of my colleagues, Dr. David McCauley, he was kind of riffing on me one day because I came here with the mandate to do cerebral palsy work. No one really knew what that meant at the time, but he was like, come here, build a spasticity program, look after kids with cerebral palsy. And I said, great. Do we have a gait lab? He said no. So then he said, well, you got a smartphone. Why can't you, make something happen with this? He's a little smart. He's a little older than I am. He thinks he's smarter than me. I don't know. We can debate this, but in his mind, he was like, you have a smartphone. You have basically a supercomputer in your hand. Do something with this. Make it do stuff. And so, I'm never one to turn down a challenge. So I was like, fine, bring it. And so we tried to define the problem a little better. So we needed to figure out a way to get kinematic information off of, or basically some way to quantify and qualify gait. And in this context, we also said upper extremity function as well, because one of my colleagues is a plastic surgeon, Dr. Kevin Chung. He also was trying to egg me on. So we said, okay, we'll do upper extremity and lower extremity. But we had some specific constraints to the technology. We said because it was coming off a smartphone, we needed to be visual information, something we could take off a video on the smartphone. And this was in the era of COVID as well. I came just as they were shutting down the borders and recognized how hard it was for patients to travel. And so we said, what if we could make this technology, if we could adapt it here, what if we could make it something that's portable as well and accessible in remote locations, trying to make it as simple as possible. So we said, runs off a single smartphone and needs to be something that, a nurse practitioner or a clinician up in Timbuktu or, Fort St. Elsewhere can actually access. So the question, could we create a clinically useful motion analysis tool using only the video data off of a smartphone? And we also collaborated with some of our engineers over at the University of Ottawa who sort of posed to us, could we actually use AI to help us with this question? So I figured it's an AI talk. I'd throw in at least one AI-generated picture. This is like just typed in doctor with a smartphone. You can tell it's an AI-generated picture. I don't know if you guys can see the hand on the left there. It's got way too many fingers. Not way too many, 6 is not too many, but it is more than you should have. And so this was the vision. Can we take a video of a child with cerebral palsy and magic, make it into, get a physician be able to look at motion analysis output on their smartphone? That was the vision. That's what I said. Went to my engineering colleagues and was like, hey, make this happen. Black magic, sacrifices, whatever it takes. And they were like, no. But they said, this is how we could potentially get to this solution. They suggested that we could apply some of the cutting-edge AI that we have access to that's commonly available to our problem. So one of the advantages we have to specifically do in motion analysis is that there currently already is a process in place which doesn't involve a gait lab. I alluded to the fact that gait labs are super hard to access, and that's true. But there are patients in all these different hospitals, all these different places that are getting care. And what they're currently doing is a manual process of actually just looking at someone and actually analyzing their gait and their motion using validated clinical scales. Super time-consuming process, super arduous to do, takes a lot of training and practice and experience, but it is currently being done. And so this makes our problem a little bit easier because since there's already something that's being done that's hard to do, the question really became, could we use AI to automate this process and make that step easier? Everyone's familiar with the modified Malay scale, Edinburgh Visual Gates? No, okay, that's fine. So this is actually what's being done. So you get basically a visual representation of what someone should be able to do, and you have a gradation for what they can't do, progressively lesser means, and you basically score it. So you basically say, can you move your arm up like this? And they get to a certain point, and you can score how good or how not good that movement is. And similarly with gait, you can do that as well. You can see that there's quite a different number of parameters here. It's actually super time consuming to do and kind of hard to do, so it's not commonly done unless you specifically need to. So we'll take a step back here and we'll define AI and the parameters of just in general and as well as how we adapted it here. Everyone's kind of familiar with the concept of AI, knows what it is, don't need to define it. This is, if you Google like what AI actually is, this is what it means. It's capability of a computational system to perform tasks typically associated with human intelligence. A lot of different things. Machine learning, AI, kind of a subset of AI. It means that you can take this algorithm that now predicts upon previous experience, kind of what we call learning. But classic machine learning doesn't really have that much ability to abstract concepts. You basically give it an input and you have to say, this is a car. Find me more cars. But you have to define exactly what features of the car you're looking for. Wheels, tires, windshield, whatever. There's, around the 90s, developed something called deep learning. It's been around for a little bit longer than that, but basically the algorithms to develop to do deep learning became more efficient around the 90s, referring to basically when you have multiple layers of processing. Like you say, instead of looking, say, cars, wheels, tires, you can say, look for a curve, or look for something black, or look for some general concept. A little more abstract. So suddenly you don't have to say, this is a car, find me more cars. You can say, this thing, find me more things like it. And it removes the need for a lot of the human interaction with AI. We already use AI all the time. Google. I Googled stuff before I came here today. DAX, ChatGPT, Perplexity. Some of these are actually supported and sponsored by CHEO. The kind of AI that I'll be talking about in detail, or a little more detail, is something called computer vision. And this has been around for like 60 years. We recognize very early on, we have a computer, we can design an algorithm to take in visual information and try to analyze what this visual data is. But, in the 50s, we're working with like computing power of a calculator. So it's really hard to do sort of advanced programming, advanced visual processing. And And it was really probably in the 2000s, like 90s, 2000s, built deep learning, as well as developed like powerful enough computers that we can take really complex algorithms and take complex visual data, abstract it into something meaningful. Take a lot of the work that people would used to have to do and give it to the AI and basically say, here's a picture, tell me what this is, or here's a picture, find more pictures that are similar to it. And this is important because a lot of the technology that we do, that our work does, is dependent on something called pose estimation. And this is a type of computer vision that utilizes that deep learning, that multimodal learning. It's been around since the 90s, and there's been multiple different approaches that developed over time. And basically what this is, and there's multiple different types of these pose estimators out there. You can go on Google. A lot of them are actually free for use if you want to just play with them. Does everyone know what GitHub is or something like that? Yeah, you can actually download the software, download an environment basically, download one of these pose estimators, upload a video, and play around with these skeletons. They're kind of fun to do. But the general gist of all of them is that you have an AI, you apply it to a video or an image, and then it figures out key points. It depends on what the pose estimator is, what those key points are, whether it's forehead, whether it's eyeballs, ears, nose, whatever, face, joints, and then it can create a skeleton or a mask. It can kind of tell you, well, this is a person. If your pose estimator is designed for people, they have ones for different animals as well, but if you have one for people, and it'll tell you this is a person, let me tell you what that person is doing at a given period of time. And you can abstract information from that skeleton. Sorry, there's another video here. Okay, it's okay. So you can see there was a video on the left that showed pre-pose estimator, but the video on the center video shows basically a patient with a pose estimator skeleton on it, one of my patients. You can see that based on this pose estimator, it's estimating the position of the patient's face, head, joints as they walk through the frames of the video. There are also pose estimators that are specific just for like limbs. Like you can get ones just for the ankle or just for the hand, which are also pretty neat too. So, coming back to original vision, this is what I gave to the engineers. Can you make this happen? Magic. They said no. But what they did say is that we can build a roadmap, we can go through an iterative process to try to get you close to where you want to be. And the actual roadmap that we built out was actually super, super long. There was like many, many more steps, many more failures, but this highlights some of the main questions that we had to overcome to get to where we wanted to be. We kind of touched on this. I also went to the engineers and said, we want this something, if we do get to the end point that we want to get to, we want this to be something useful, especially the patients that we serve and the clinicians we work with. So we wanted to make sure that this was something that we could adapt and send out to the community, to clinicians who don't have access to Gait Lab as well, but who don't have access to even subspecialty training, but do look after our patients. So the first question we asked was, I've talked about AI, I've talked about, applying to video. Can we actually do this? Is this fundamentally a possible thing? Can we take a pose estimator and apply it to a smartphone video? Because we don't know. Smartphone videos don't really generate great quality video sometimes. You're shaking your hand. Resolution's not a little bit dicey. Does it work? Yes, thank God. It was like the first step that we passed, and it was great that we actually got this fundamentally to work. And this was kind of a fun step, because then we said, well, which one do we actually pick? There's like 30 or 40 different pose estimators you can choose. They're all off the shelf. It's like trying to pick a car. They all do the generally same things. They all have wheels, they all have a steering wheel, they all hopefully keep you warm in winter. Which car do you drive? And this was fun because we discovered things that we didn't know that these pose estimators would do. There's different advantages and disadvantages to each, but we learned along the way. We had to go through the step of trying each one, applying it to a video. For example, the first two pictures you see on this slide, I don't know if you can see clearly, but it's actually a picture off of a smartphone. Like it's a video of a video. And this was interesting because we found out that the pose estimator that we applied didn't actually work on native video. Like if you took a video, it wouldn't work on that. You had to take a video of the video to make it work. Like it makes no sense. But this is what some of these things will do, and you don't know until you actually put it into practice. And then we went through the step of trying to figure out, well, okay, we know fundamentally this works. What makes it work better? What makes it work less? Like what makes it work less better? And we wanted to figure out, are there specific variables or things that make our pose estimation like less good? And this seems kind of common sense, but as I've been told many times, common sense is not common. The picture on the left, you'll see these are some pictures or some scenarios where the pose estimator doesn't work. And you'd think it'd be intuitive, but it's not. Like if you take a video of someone and you don't include their head or their upper body, it won't tell you that this is a person. Like, it makes sense. What we also discovered was that if you have multiple people in frame, it doesn't work so good. This is me, a terrible posture, but if I'm wearing scrubs, it covers up the ankle and the joints, and the pose estimator struggles with this. It doesn't really know where the joints are if you're covering them all up. This is another patient, and you can see what happens initially when it's just him by himself. Fantastic. Skeleton labels all the joints, works well. As soon as you get another person in there, suddenly it confuses the pose estimator. It doesn't know who's who at any given point in time. And the skeletons, it's a little hard to see, but it kind of flickers in and out. And that's really bad for us because then it doesn't give us information about that joint. It tells us that the joint is moving this way and suddenly the joint is a foot away in someone else's joint. And this is something that we also learned, that even though these pose estimators are supposed to work with multiple people, they don't consistently work with multiple people. It doesn't know who's who at any given time. So this is something that we had to figure out how to resolve. So the magic sauce, how do we actually take this information that we get off the skeleton into clinical interpretation? And this was a lot of work. This was the biggest step and sort of the secret sauce to everything that we did. And it took a lot of hours of master students, PhD students, people grinding away. And a lot of it just came down to trial and error. We just tried different things, didn't work, failed, went back to the drawing board, tried again. And I can't highlight enough the importance of perseverance and patience during this step. I mean, we just knew that we wanted this to work. We tried different things. We shared our experiences with other people, even when we failed. And that was important because I think it validated our process. But it just took a lot of time. But eventually, our efforts paid off. We could see that we were starting to get closer and closer to what we consider ground truth, what we wanted to show. We could see that our pose estimator was getting better and better at maintaining and then spitting out a clinical output. And the nice thing with our process, the nice thing about a visual interpretation is that we have a gold standard. I kind of alluded to the fact that this is already being done by people. People are already looking at videos and they're interpreting it and they're providing clinical output. And so we had a gold standard to compare to, which was super helpful. So we could see that our initial algorithmic approach, our initial attempts at trying to translate this information into a clinical score, what's green here is that this suggests that this parameter of gait is actually correlating well to how a human would interpret this. There's a few parameters, like 3 of them, which don't do so great. And that probably reflects the fact that people scoring these specific parameters also don't do so well. But we found that overall, we could get a pretty reliable interpretation compared to a human. And this shows kind of the same thing for the upper extremity as well. And then we decided to expand out to larger validation studies, which I think is important. Anytime you're testing technology, you've got to show that it actually works. It's doing what it's doing. So then we expanded out to just over 100 patients with CP. We took an existing database from one of our collaborators. And these are videos that weren't designed for AI. These are just someone was making videos for their own clinical use. And we just applied our algorithmic approach to this to see what we could do. And what we found was that, over several iterations of improving our algorithm, we're getting better and better. We're getting better and better correlation to what a human would look at. Ideally, we'd like it all 100%, but if you reach an 80, 90% correlation to a human interpretation, that's not bad. It's not bad. Getting better. And then when we actually, again, after several iterations of improvement in our algorithmic interpretations, we started a prospective study here at CHEO. In our initial cohort, what we're seeing is that we are getting closer and closer to that 100% across the board, to comparing how our algorithmic interpretation compares to a human interpretation. Some are still a little bit lacking, and I think we need some more time with that. But overall, I think we're seeing progressive improvements in how we do. So the final question we got to was that, how do we actually make this information useful to people? What does our output actually look like? And this is an area that we're still working on. The easy thing to do would be for me to say, the output looks like this. Here's a picture. Deal with it. But I think that's not super helpful for many of our clinician colleagues, and I don't speak on behalf of many people. I'm like a borderline autist. I think that I have a very fixed impression of how things should be, but that probably isn't necessarily applicable to the whole population who deal with this population, or who deal with these kinds of patients. So we elected to actually do a prospective multi-center study, which we're hopefully submitting soon, with the goal to enroll physicians and clinicians across the country, as well as the far north. Get their impression, see what they want to use, how they might use this technology, and how they might apply the output of this technology. So my impression, my first thought was that this is what we wanted. But in reality, maybe this is what people actually do want. Maybe they want a video with dots and they want like be able to see a body map. Maybe they want like a kinematic graph in the middle. Like this is what you traditionally would see with like a gait interpretation output. You actually want the velocity graphs and the position and time graphs. Maybe this is what people want. Or maybe they want like an abstract representation. This is what we're hoping to find out. So where are we now? You can actually see our application in action. This is like the data acquisition application. And this is designed to basically constrain the input. That's one of the things we learned, was that if you put garbage in, garbage will come out. But if you can constrain what comes in, if you can create an application that actually tells you good, bad video, you can actually really improve your results. And so this is what this application does. And again, this is one of my patients who actually is in the far north. And this is our application in action, running, applying a skeleton. And this is her output. So we're actually getting reliable clinical outputs now. Now what's green is actually telling you normal versus abnormal. So yellow is slightly abnormal, and red is really abnormal. So what we're seeing is basically a reliable output in terms of interpreting what her actual movement abnormalities is. In case you were wondering, this is a girl who actually, I don't know if you can see, she shaved half her head. She didn't shave it, I shaved it. She had a terrible brain injury, so she had some pretty significant deficits. But potentially now, instead of having to travel down to Ottawa to be assessed in person, maybe she can get this done by someone in Sudbury, and we can get that information. We'll see. And I kind of simplified the process, but this is basically the steps that we had to learn, that we had to go through to actually build this pipeline out. There's a lot of different go, no-go steps, but it was a helpful process, helpful exercise for us to understand that you can't just go from point A to point B. You got to work through all the different potential failure points before you can get to the output. So I'll take a minute now just to talk about what I learned from this process in general. This was like a many-year process. I learned that it's feasible. You can take these AI tools that currently exist. You don't have to necessarily develop your own AI tools, but it really takes a clear understanding of the problems at hand. And sometimes the problems seem so big, and it's really important to break those problems down into small, digestible parts. And what I found was really helpful was finding experts in those small, digestible parts in order to move the project forward. You'll recognize some of the people in this slide, I think. Some of them are probably your peers and colleagues in this room. And they were sort of foundational in sort of driving this project, putting it together initially. But we found that we needed more expertise, more help. We needed more people to sort of understand the problem, try to move things forward. And so our team grew over time, and it continues to grow. And if anyone's interested, I welcome any sort of collaboration or any ideas that people might have. It does take a lot of patience. This was a 5-year more process, lots of trial and error. And one of the things I think that kept us going was that we found value in the journey. We published our results even when they weren't good. We shared our findings. And if you want to get just to the end, I think you'll never make it, because to go from where we wanted to be and where we ended up, if we tried to do that one step, I think we would just given up within 6 months. It was just such a pain cave. But we found value in the actual learning. I think our students found value in the learning, and I think that's something that's really important if you're going to try to endeavor doing an application like this, is to try to enjoy the journey as much as the destination. And why do we have this technology? I think that at the end of the day, this technology is really important to improve motion and functional assessment using the tools that we currently have. Potentially, this allows us to evaluate patients in remote settings or those not otherwise able to come to, say, CHEO, like a subspecialty center. And this automated process does improve or reduce the need and time for specialized technologists and clinicians. We think it's more reliable and more efficient, but this is something that we're trying to prove. We do have ongoing steps with this. I don't know if people are familiar with the CHEO. It's a functional test for upper extremity movement. Instead of just trying to get someone to raise their arms up, now we're saying, take this dollar bill out of your wallet, or move this coin over here. So pretty high level stuff. So our goal is if we try to operationalize this process to these functional tests. and maybe even do predictive modeling. Can we predict for when someone, based on their gait, is going to fall? It's kind of interesting. This technology that we're developed for CP patients, we're seeing actually a lot of interest in places like Briere and other centers where, falls is a big deal for them, and they want motion analysis because they care about whether patients are going to tumble over or not. And as I alluded to, what we would like to do, or what we'd like to assess, is can we actually do this to remotely evaluate patients? Maybe here in Canada, maybe you're far north, maybe instead of having to bring a patient down from Inuvik, they can stay up there and then we can do some sort of remote assessment. But maybe there's an opportunity to use tool in places like Ghana and like more resource-limited settings as well. We have some collaborators who are starting to come out of Africa who reached out to want to work with us. Still a lot of challenges ahead. We don't really know what our output will look like. We do want people to let us know. But I think one of the big steps, one of the big challenges that we have still is how do we integrate this into clinical care? Where in the pathway for management of patients does this go? And how do we validate that process? As well as cost. Some of this work is, a lot of this is done under the guise of research, under the auspices of a research grant. But at some point, if someone wants to use this for clinical care, how do we pay for that? How do we pay for server costs? How do we pay for analysis, data transfer? I've alluded to the fact that we decided to commercialize because we thought that would be the best way to get this technology in the hands of people. But is that the best approach? I don't know. We'll see. See if I'm bankrupt in a year. Thank you, everyone, for sticking with me to the end. I appreciate your time and your patience. Hopefully what I showed is that automation of visual, gait, and motion analysis is feasible and viable for patients with cerebral palsy. And hopefully there are other conditions where this technology could also be of value. I think the tools to potentially address many of the problems that we face do currently exist, and it's important to find the people who actually know how to use them and to work with them, and to be patient with the process. I don't think I learned very quickly. This is not something you can do in 6 months, but I found value in that whole learning experience. Thank you, everyone, for your time. Appreciate your patience. Open the floor to any questions or comments.
You can see the.
Perfect. Thanks so much, Albert, and thanks for putting up with the noise next door. I know that can be a bit distracting, but I think this was an amazing example of how AI can be applied and how we push this concept of the AI scientists or the engineers needing to work closely with the clinicians and with the patients and families as sort of as a joint prospect. And thanks for your words of wisdom and sharing the painstaking process and the perseverance. Much like with any sort of research project, it doesn't happen overnight and requires patience and trial and error. So, questions for Albert?
Very nice
Sean.
talk. So the primary goal is to help patients with CP to understand the gait in terms of having the correct intervention. Are you foreseeing this to go beyond this particular indication?
Do you mean within CP patients, or do you mean?
You want to just repeat the question?
Yeah, we're going you to summarize for the.
Sorry, Sean. Thank you for the question, and I just want to clarify. So, your question is this technology just how can we generalize this technology for CP patients, or do you mean
Beyond CP.
And the question is how, or
Can you?
yeah. The question is, can we actually generalize this technology beyond the CP patients? Yes, that's the goal. I think motion analysis, part of the reason we do motion analysis in just cerebral palsy patients is because we think that that's like the population that needs it the most. But that's not to say that there's other populations that wouldn't benefit from it. Movement disorders is super common. It's just that we've never tried to do these tests in patients who have Parkinson's, patients who have multiple sclerosis, patients who have spinal cord injury, because it is so hard and labor intensive to do in the first place. With potentially, we don't really know how to interpret that data because it was hard to get the technology. I think potentially now that if we can make this technology very accessible, I think there are a number of other conditions where we can start looking at maybe it's important to do objective motion analysis in these populations as well, now that we've given them the tool to be able to do it easily. I hope that answered your questions. I'm not sure.
And Albert, you alluded to like older adults and Bruyere, and as you know, a lot of this work has been supported by our core innovation team here. That's funded by a federal grant along with Bruyere. And as we think about it, many of these challenges that our population of kids face here, older adults may face with different conditions, but similar issues around, movement and hearing and vision and those types of things where technology could be beneficial. Any other questions?
Just, why do you think the foot, ankle, heel lift is one of the ones that's hard to get?
Oh, that's a great question. So the question was, why do we think the foot, ankle, heel lift is so hard to get? So two reasons, I think. One, what we discovered was that AI computer vision, as good as we think it is, still struggles a lot. I can see where Jason's beautifully manicured shoes reach the floor. But a computer vision algorithm would struggle with that. At any sort of interface, it's hard for it to tell exactly where something ends and something begins. I think the algorithms are still trying to figure that out. They're still trying to refine those algorithms. The second reason is because people also struggle with figuring out interfaces. And specifically at the foot and ankle, if you're trying to figure out exactly when the contact point of someone's walking is, it's really hard to time that perfectly. Even as a person, you're like, maybe it's here, maybe it's a second earlier or a second later. And so when your gold standard, your reference standard is a little bit questionable, so if we're comparing to a human's best guess, and the human's best guess is not great, that means that our ability to compare reliably is probably also not going to be great. So the way we're trying to address this, and the way I think many people are trying to address this, is one, we're trying to figure out a better algorithm, trying to figure out a better computer vision model. We're taking something off the shelf we've modified in a few ways, but there's people trying to figure out better algorithms. But there's also, I think, ways for us to constrain the data coming in, try to time it, or try to come up with a way for the AI to figure out exactly when to take that data point. So we're trying to figure it out still, but I think it will be a challenge for us. Yeah, great question.
Albert, I have a question. You talked about the fact that the algorithm maybe had challenges when people had clothing on. And of course, if people are doing this more remotely, maybe they're more comfortable being in their undergarments at home as opposed to in a cold examining room. But I wonder, will you be able to adjust the algorithm eventually so that people will be able to do it clothed, so that way you can actually, maybe you can do it with people when they're outside or doing more functional movements, going up and down their stairs, that type of thing?
Yeah, a great question. So the question was clothing and its effect. And so actually, I should have been more specific. Baggy clothing makes it hard to do. So scrubs, not great. But if you're wearing like tights, Lululemons, if you want to get around your joggers, actually it seems to be pretty reasonable. So, if someone wants to do this outside in their jeans in a field, we haven't tested it in that kind of setting yet, but I suspect it actually might work okay.
Jen.
Hi, Albert. So commend you and the team for your perseverance on this. It's really exciting. Thank you for sharing it. And so I have a sort of personal and professional interest in AI, and I'm constantly learning about it. So by no means an expert. And so maybe this question is not particularly relevant, but I'm curious as to whether you think that this could help to further work that I know is happening around the concept of digital twins. And so if you think about a patient having a digital twin, and, could this be an input into that to help determine, the course of treatment for that patient or the future possibility? Because I hear you that this is, potentially beyond pediatrics, but I'm also thinking, how does it become part of how we care for the patient as they further develop with their age, with their stature?
Oh man. So I'm going to repeat the question. So
how define the digital? I don't know. Jen wants to
Yeah.
Because not everyone may be familiar with that term.
Yeah, I probably not do it justice, but my understanding of it is it's an opportunity to take what we know about a patient and almost create sort of this persona based on that patient.
Like an avatar.
Yeah, almost. And then it can be, I've seen it applied in many different ways, like for surgery and creating kind of a roadmap of who that patient is and how that supports kind of, planning for surgery and making sure that it's the most safe surgery possible. Or, just, I'm sure there's others that have more they can share about it, but.
Yeah, I'm going to rephrase the question and for the audience, but I'm not sure I'll do it justice as well. So the question was, how does this feed into creating a digital twin or a digital avatar? The simple answer is, I don't know. I've never even thought about that. That is a fantastic consideration that didn't even cross our minds. And I think highlights the fact that I would love to work with you, or to get your input, because this is not an area that I'm familiar with. But if it's an opportunity for us to help create that, or create this technology, or create this avatar, make it better, very much supportive of that. Yeah, I think that what we've created essentially, I think, is like a Lego block, and it's kind of up to people out there. Our hope is that it's up to people out there, other people interested in this field, to take those blocks and build something better with it. Pranesh, did you have a question?
Yeah, it's not nearly as good as Jen. I was thinking back to the limitations of the video interpretation. I noticed in many of your videos the patients who were disrobed had little stickers on them.
Yes.
And, that got me wondering, in terms of multimodal sensory input for the AI. So, would you ever put a sticker on the key joints, maybe not just for visual inputs into the model, but other types of positional sensors, right? That would also help. So it just got me thinking, when do you use the stickers, and are they only visual, or could you use other, so use it for other sensory input?
Fantastic question. Super observant. I got to pick better videos. So Dr. Chakraborty's question was, why do we use those stickers, or why do the patients have the stickers, I guess, would be first question. And second question is, could we actually put other types of stickers on to get other types of sensory input? In response to your first question, it's because those videos were actually not designed for this application. Originally, they were actually designed for manual abstraction of the data. So the way you do this manually is that you would run a video of someone. You're sitting in front of a computer screen or a big TV monitor, and you're literally running the video slowly over time. And there are currently technologies, software programs to help you with this. There's a software program, for example, called Dartfish, where you basically, on that video, you can manually apply the skeleton. Kind of like a version of computer vision, but without that deep abstraction, so it won't automatically apply skeleton. You got to draw out the lines. So those markers are visual references for someone doing that, to draw out, where's the midline, where's the hip, where's the knee. That's why those patients had those markers, was for that manual process. To your second question, could we actually adapt sensors instead of having visual markers? Yes, 100%. And that's actually some of the work that I think Kevin Smith's doing something like this, where he, instead of using the smartphone video-based approach, I think they were actually using the smartphone as an accelerometer. They strap it to someone's knee and kind of see what the movement was like. I'm not sure how far they've gotten in their technology. We were kind of competing in the same space for a little bit. Competing, he's much bigger than me. Not much of a competition, but it is something that we've talked about, and I think something that will come down in the future. As I've alluded to, many gait labs, like there's many different sort of brands of gait labs. Some of them are purely camera-based, but a lot of them have force plates, and a lot of them actually include EMG as part of their processing. And so maybe that's something we consider if we need higher fidelity information. Maybe there's a version where you have a smartphone, and then you have a second smartphone or some sort of accelerometer you slap to the knee to also get that additional information. Yeah, great comment, and definitely something that we're considering.
The other thing I would add is you'd mentioned the gait lab, and we know in the new integrated treatment center, there's going to be the building that's going up outside. We're going to have a lot more space to be able to house and support the infrastructure for a gait lab. I don't see any questions online. Any more questions? I'll remind people that the evaluation link is in the chat. Thank you, Rachel. So please complete the evaluation. And if there's no further questions, please join me in thanking Dr. Tu for a fantastic grand rant.